All right, let's jump right into this. Welcome to this explainer, which is designed to be your ultimate step-by-step clinical guide to mastering the comprehensive knee examination. If you're a focused learner trying to cross that bridge from textbook theory to actual hands-on clinical confidence, you are in exactly the right place. We're going to take universal medical terminology and blend it with a super practical approach so you can accurately assess and diagnose knee pathologies like a pro.
Here is our roadmap for today. First, look, feel, and move. Second, assessing the patella. Third, testing cruciate ligaments. Fourth, testing collateral ligaments. And finally, number 5, checking for meniscal tears. Let's get to it.
Starting off with Section 1, look, feel, and move.
You know, it's funny, but your exam actually starts the exact moment the patient walks through your clinic door. You're already looking, right? You're checking their gait, keeping an eye out for any varus or valgus alignment weirdness, and then, once they're actually up on the examination couch, that's when you're scanning for muscle wasting. You really want to pay attention to the VMO, the vastus medialis obliquus muscle of the quadriceps. After looking, you've got to use your hands. Feel for any localized temperature changes. A hot knee? That's a huge clue for inflammation. And of course, meticulously palpate for joint line tenderness. Trust me, finding that tenderness is often a massive indicator of underlying joint pathology.
Now, when you're assessing movement, there's a huge red flag you absolutely need to watch out for, and that's called an extension lag. So what does this mean? It's basically when a patient just cannot straighten or actively extend their knee using their own muscle power. But, and here's the kicker, if you lift their heel, the knee passively goes right into full extension. So the joint works, but the motor driving it doesn't. This specifically points to quadriceps weakness or some kind of disruption in the extensor mechanism. And just to be super clear, this is totally different from a fixed flexion deformity, where the joint is physically stuck and literally cannot be straightened at all.
Moving right along to Section 2, assessing the patella.
So our very first specific maneuver here is the patellar tap test. We use this to hunt for a major joint effusion or swelling. Here's how you do it. You place one hand right above the knee and you squeeze. You're basically milking that fluid from the suprapatellar pouch straight downward. Then, keeping that downward pressure totally locked in, you take the index finger of your other hand and give the patella a quick, sharp tap. If there's a ton of fluid trapped in there, you're going to feel the kneecap kind of float downwards, followed by a very distinct, well, a clunk as it hits the femur underneath. It's a very satisfying diagnostic feel, honestly, even if it is a concerning sign for the patient.
Next up, we've got Clark's test. A lot of people just call it the patellar grind test. This one is a go-to for identifying patellofemoral osteoarthritis or chondromalacia. You take your hand, place it just above the superior pole of the patella, and you apply a really gentle downward and inferior pressure. Just gentle, okay? Then you ask the patient to actively contract their quads. Now, a quick warning here. This test can seriously hurt the patient if it's positive, so you've got to be careful. What you're looking for is a pain response, and you're feeling for crepitus, that crunchy, grinding sensation as the patella rubs against the femoral groove.
Okay, so we've checked the surface, we've looked at the muscles, we've tested the kneecap. But what if the damage isn't visible on the surface? How exactly do we uncover hidden instability that's buried deep inside the knee joint? Well, we have to pivot our diagnostics inward. That brings us to Section 3, testing cruciate ligaments.
Now, before we start doing these specific tests, we really need to talk about what your hand should actually be searching for. It all comes down to this core concept called the end point. When you stress a healthy ligament, you should feel a sudden, extremely distinct, firm stop. That firm end point, that's the ligament doing its job, telling you it's intact. But if the ligament is torn, that sudden stop just vanishes. Instead, you get this soft, mushy, or delayed endpoint. And let me tell you, when you feel that soft endpoint, alarm bells should be ringing in your head, because it is a massive red flag for a rupture.
All right, let's look at the bread and butter of knee exams, the drawer tests. For both of these, you want your patient lying down, hip flexed at exactly 45 degrees, knee at exactly 90 degrees. And here's the fun part. You actually have to sit gently on their foot to anchor it. I know, it feels a little awkward at first, but you absolutely need that leverage. So for the anterior drawer test, you grip the proximal tibia and you pull it straight forward towards you. That's checking the ACL. On the flip side, for the posterior drawer test, you push the tibia straight back away from you to check the PCL. All the while, your brain should be 100% focused on judging the quality of that endpoint we just talked about.
Now, if we're talking about the absolute gold standard for detecting ACL injuries, we are talking about the Lachman test. Why is it the best? Because you do this with the knee flexed at just 20 to 30 degrees. Mechanically speaking, this specific angle is magic.
It totally isolates the ACL by taking all the other stabilizing structures completely out of the equation. So you stabilize the femur with one hand, and you give a sharp, firm pull forward on the tibia with your other hand. Again, you are searching for that solid, firm endpoint.
But hey, let's be real in clinical practice for a second. Sometimes a patient's leg is just too large to comfortably get your hands around for a Lachman test. And that is exactly where Lilly's test, or the lever sign, comes in to save the day. It is a brilliantly simple mechanical alternative. You literally just place your closed fist right under the upper third of the patient's calf. Then you press down firmly on their lower thigh. If the ACL is intact, it acts just like a tether. That downward push on the thigh will make the heel pop right off the bed, like a seesaw. But if the ACL is torn, the tibia just slides forward and that heel is going to stay completely glued to the table.
So we've got front-to-back stability completely covered. But think about an athlete making a sudden, sharp cut on the field. They desperately need side-to-side stability. So what exactly is keeping the knee from just buckling inward or outward under all that stress?
Let's find out in Section 4, Testing Collateral Ligaments.
To test these side stabilizers, we use opposing stress maneuvers. Let's start with the valgus stress test. Here, you're pushing the knee inward while pulling the ankle outward. You're basically trying to pry open the inside of the joint to test the MCL. The varus stress test, that's exactly the opposite. You push the knee outward, stressing the outside to test the LCL. Now here's a massive pro tip. You've got to perform both of these tests twice, once with the knee dead straight at 0 degrees and once slightly bent at 30 degrees. If that joint opens up at 0 degrees, you are likely looking at a really severe multi-ligament blowout, not just a simple sprain.
When things get really complicated, we bring out the dial test. This one is absolutely fantastic for sniffing out issues in the posterolateral corner, or the PLC, which is notoriously tricky to diagnose. Have your patient lay completely prone, flat on their stomach. Then you bend their knees to 30 degrees, grab their feet, and forcefully rotate them outwards. You visually measure that angle. Then bend the knees to 90 degrees and do the exact same outward twist. By comparing how asymmetrical those rotations are at the different angles, you can actually figure out if it's just an isolated PLC tear or a much nastier combined PLC and PCL injury.
All right, home stretch. Section 5, checking for meniscal tears. So, we've cleared the ligaments. Let's talk cartilage. The absolute classic test here is McMurray's test. It involves some pretty complex hand mechanics, but the goal is simple. You are trying to physically trap a torn flap of meniscus. You start by fully flexing the knee. To test the medial side, you externally rotate the foot and apply that valgus stress we talked about earlier. To test the lateral side, you internally rotate the foot and apply varus stress. While you're holding that awkward, twisted tension, you slowly straighten the leg. All the while, your fingers are clamped right on the joint line, waiting for a very palpable, painful click or clunk.
Next is Apley's test. The patient is prone again with their knee bent pointing straight up at 90 degrees. I love this test because it's a perfect lesson in differential diagnosis. Step 1. You push straight down hard on the heel while twisting the foot. This is the compression phase, and you're literally grinding the meniscus. If that hurts, it's a cartilage problem. But then, step 2. You pin their thigh down with your own knee, pull straight up on their foot, and twist again. This is the distraction phase. If pulling up is what hurts, then the meniscus is probably fine, but you're stretching damaged ligaments or the joint capsule.
Finally, let's talk about the Thessaly test. Look, sometimes a patient has a meniscal tear that is so stubborn, it only ever hurts when they are standing on it. Static tests on an exam table, they might completely miss it. So for the Thessaly test, you get the patient up, they stand flat-footed, balancing entirely on the bad leg, with their knee bent to about 20 degrees. You hold their hands just so they don't fall over, and then you ask them to actively twist their entire body left and right. This throws a massive amount of dynamic, weight-bearing, rotational torque directly into the meniscus. It is fantastic at recreating that telltale catching or locking pain. Well, we have covered a massive amount of ground in this explainer today, haven't we? From the basic patellar tap all the way up to the ninja-level mechanics of the dial and Thessaly tests. But here's the thing. You can't just memorize these tests. The true art of diagnosis, it lives entirely in your hands. The only way you'll ever confidently know the difference between a firm and a soft endpoint is by getting those clinical reps in. So I'll leave you with this final question to chew on. Which of these specialized clinical maneuvers are you going to practice and perfect first? Get out there, start practicing, and trust your hands.